Hi guys, so in this video I'll be telling you how to approach surgery because we have a surgery exam in uh, 3 days and we have a lot of portion to carry. So first thing you need to be very comfortable with is swelling and ulcer. This you would have seen in your clinical posting. So when it comes to swelling, site, shape, and then site size, shape, and then plane of the swelling, then compressibility, the contents of the swelling, and then transmissibility, reducibility. All of these factors play a huge role, and this will help you fill up answers in the sense you can write all of these as clinical features in under science, and then this is the first thing you need to know. The second thing is the anatomy of the relevant organ. What I mean by anatomy is, first of all, you need to know what are the parts of the organ. Second, blood supply, arterial supply and venous drainage. Lastly, your lymphatic drainage. Uh, all these three are important because any problem in any one of these is going to be your pathological features. And then three, you'll have a little bit physiology of the organ. Okay. Uh, Along with this anatomy, you need to know relations. This is the most important thing, relations, because any kind of problem in surgery where you enter, you need to know what are the surrounding structures so that you don't damage it and you find the correct structure. Okay, so this is the strategy to approach your surgery theory as whole. This covers only the abdomen, urogenital, breast, thyroid glands, all of those parts. The general surgery is different, so that is a basic pathology content like inflammation, tissue repair, and then shock, and then burns. All those are like your basic pathologies. Those won't be covered in this. Your anesthesia, your pre-operative, intraoperative, post-operative things. Those things are common points for all the questions which you can use. So I'll give you example of maybe three organs today because uh, I myself haven't gone through it. So whatever I'm speaking is of long-term retained information. I have not gone through for this session. A lot of people have been texting me saying that so much surgery is there. How will we be able to be cover it in one day? So the biggest problem is everyone is going question wise. Like you take okay, three organs. We'll choose our stomach, breast, and thyroid. All right, all three are very important questions in the surgery exam. So if you take stomach, there might be 12 important questions, okay, and breast there might be 10 important questions. Thyroid another 15 questions. So that makes that like 35, 40 questions which you need to go through individually, right? So with this method, you can essentially club everything together and you can retain only what's necessary. Okay, so let's start with stomach. So this swelling ulcer is for clinical features. I won't be mentioning that in this video because I haven't gone through that myself. I'll make mistakes in those, but your anatomy is something which you can I remember a little bit. So you draw your stomach first of all, okay? So this is your stomach. Now parts of the stomach. So this is the lower esophageal sphincter. This is the fundus, body, pylorus, pyloric antrum. Those are the parts of the stomach, and then you have certain relations, right? This is the greater curvature. This is the lesser curvature. You have your peritoneum here, your greater omentum and smaller omentum over here, and then here you have something called trough space. Here you will have your spleen. Here you will have your liver, and on top you will have your lungs. So this is all important for your spread of the cancer if something like that comes. Okay, so this is the basic anatomy which I remember off my head. Next is your blood supply. So your blood supply. Okay, so blood supply is going to be from your celiac trunk. So from your celiac trunk, you have one splenic artery like this, and then you have your common hepatic artery. From that, you have your right gastric artery, and directly from your celiac trunk, you have left gastric artery. This will spread. This will split over here, and this is your hepatic artery, and then this is your pancreaticoduodenal arteries. Here you'll have one branch. This is your gastroepibloic, your right gastroepibloic artery. From spleen, you will have your left gastroepibloic artery, and here short gastric arteries. So this is the blood supply. Okay, and then the venous drainage. You have a portal vein over here. You have your inferior mesenteric, a splenic vein over here, and inferior mesenteric vein drains in the splenic vein, and then you have your superior mesenteric vein over here. You have a short gastric artery over here, and then two arteries over here. It will be similar like gastroepibloic. This will be pancreaticoduodenal like that. This is the basic thing. You get it right. I'm not. I don't remember the names properly. So that is there, and then you have your lymph nodes. So for lymph nodes, you will split it like this: 1, 2, 3, 4. You have you have your pancreaticode, one group of nodes over here, one group of nodes over here, one group of nodes over here, one group of nodes over here. These are your right and left gastric nodes. I think this is pancreaticoduodenal nodes, and everything will drain finally into the celiac node. You will have a group called hepatic node over here. So this is your lymphatic spread of the stomach. Okay. Now, what are the functions of the stomach? Are functions is going to be HCl production, and then intrinsic factor. This is helpful for B12 absorption. Okay, and then transport of food. This is an important function because this is important in case of gastric outlet obstructions. So now with this so much, this is only how much you need to remember for your histology is another important thing. So in any abdominal organ, you have 4 layers. So you have your mucosa, submucosa, your muscular layer, and your peritoneum or serosa. Okay. Then you have 2 plexus, your submucosal plexus and submyenteric plexus. So these plexus are known as the brain of the gut. Okay, so they help in peristalsis and all those movements. If this is damaged, then that is not going to take place. So that is all the thing you need to remember when it comes to anything related to the stomach. So what are all the various questions of the stomach? You have peptic ulcer disease. Okay. You have gastric cancer. These two are the most important ones I'm able to recollect right now. For all of this, you need to know one important thing is your H. pylori. This bacteria is very deadly because it has something called acid hydrolase, and it will secrete ammonia. This ammonia will go and stimulate gastrin. Okay, this gastrin will increase HCl secretion. So that is why you have excess HCl, and when this excess HCl is in contact with this mucosal thing, it starts eroding, and that's how you start getting your ulcer. That is only a peptic ulcer disease. Okay, so there are some protective factors like one, your mucosa. Mucosa will secrete mucus, so that is one protective mechanism. And then there are some 2-3 more mechanisms which I'm not able to recollect right now. But you see, that is all you. So you, if they ask anything about the stomach, you just mention its parts, its areas, and peptic ulcer disease. Now, how do you add bulk to your answer? Is you take the anatomy. So you have fundus. This is the cardiac region. and then body pylorus, right? So peptic ulcer in various areas, cardiac, it's not common over there. It's either body or pylorus. So a peptic ulcer classified based on anatomy, your body of the stomach, pylorus of the stomach. So when it happens in the pylorus of the stomach, what will happen ultimately? Something called cicatrization. So wherever you go, this inflammation is going to haunt you. So you better know it properly. So whenever you have inflammation, you will have neutrophils coming, okay, and then there will be a cell destruction, and finally you will have fibrosis. This fibrosis is only the biggest problem because this normal tissue is replaced by hard tissue, connective tissue. So that is not going to do any function other than it will be shrink. Like for example, it's like a rubber band holding together two uh, dead two working parts. That's one dead part. That dead part is replaced by fibrous tissue, which is like a rubber band attachment in between. So it'll essentially shrink that area is what I'm trying to say. That's why you have pyloric stenosis. So that is what I remember about stomach. Other than that, if this lower esophageal sphincter is damaged, then you will have your gastroesophagus reflux disease. So in that, what happens is the esophageal, the squamous epithelium is converted into columnar epithelium. All of those. So what are the symptoms when it comes to stomach? Are one, you can have dyspepsia. Okay, then you can have bloating. You can have vomiting. Then I said no that pyloric stenosis and you have gastric outlet obstruction. So you will have delayed vomiting, and then you will have stomach will get distended. So you will have visible peristalsis. So as you can see, I can keep adding points to my question. Whatever you ask, I will go to the anatomy. Then I'll see what type of disease it is. So you take gastric cancer, okay? Gastric cancer is going to be classified based on this histological thing only. Your early stage disease is going to involve your mucosa and submucosa. That is your early Japanese classification. You will have something like this, and then like this, then two layers like this. There are some 1, 2, A, B, and 3, and then you have another classification based on the type of lesion. You will have first one bulge like this, then there will be ulcer, finally it will be fully spreading throughout the thing. So that is how you like remember very little, but with this you can write a lot of stories. So I was talking about the clinical features, then investigations. So when it comes to anything to stomach, no, it's like one hollow tube only. So you can put one camera inside it and look from down from up. So that is your endoscopy. Okay, endoscopy is again of two types. You have rigid endoscopy and flexible endoscopy. That just the flexible ones are the newer ones. Okay, then you can do ultrasound, you can do X-ray, you can do barium studies, you can do CT. This is not usually done, but these are all commonly done. Okay, then treatment. So what are we going to do? We are going to remove the stomach. So the basic term is ectomy is removal, ootomy is putting a hole. These two terms are enough. Okay, so you are removing the stomach. So that is gastrectomy. Okay, if you remove this part, what will happen? There will be one gap over here. So that gap, what you do is you either you connect it to the duodenum or you connect to the ileum. If you connect it to the duodenum, that is Billroth type 1 surgery. If you connect it to the terminal ileum, that is Billroth type 2 surgery. Okay, that is your treatment. Now that is surgical treatment. Then you can add in your medical treatment like PPI and then triple regiment, all of that, H. pylori for all of that, and then your surgical. Surgical you need to mention pre-operative, intraoperative, and post-operative. Okay, so pre-operative is your anesthesia component. Intraoperative, you need to make sure there is no damage to nearby structures. Post, two things: hemorrhage and infection. Okay, that's all. So that is all about stomach. With this, you can almost answer any question they ask in stomach. So this is all you need to know. Then breast. When it comes to breast, you have your normal development. So maturation of breast. Then for that you need to know about estrogen, progesterone. Then estrogen is enlargement of the breast as a whole. Progesterone will increase the glands, but I'm not sure about this. Please do read everything what I am saying, because I haven't opened my textbook. Whatever I'm saying is out of long-term recalling, and I just want to show you how to make it easier, and that is why that's the whole point of this video. It's not me teaching you the whole of surgery. I'm hardly in my final year MBBS, so I am not a surgeon to be very precise and all, but this is what I know, and I hope this will help you guys. So your estrogen progesterone, that is over. Then your normal anatomy from second rib to sixth rib, from your lateral border of clavicle to your mid axillary border. Then you have one axillary tail of Spence over here. Then your parts are going to be the breast hole, and then you have areola and nipple, and then and then your lateral thoracic artery is your blood supply, internal thoracic artery from here. Then lymphatic drainage, you have your axillary group of lymph nodes. You have four groups: anterior, posterior, medial, lateral, and then you have here your subclavian group, and then one more. Before that, there will be one intermediate group. That is your lymphatic drainage, and then you have this one group over here, one group over here. You spread it into four, and then your anterior is the most draining. That is the lymphatic drainage of the breast, and then blood supply, lymphatic drainage. Then you go part by part. So you take areola, something attached to areola is Montgomery tubercles. That will happen in pregnancy. That's little more anatomy which you need to know. This diagram is very bad. So this is your breast. You have all your ducts and lobules. Okay. Then this thing called ligament of Cooper is there. This is your clavipectoral fascia. You have your pectoralis muscle over here. Then your pectoralis minor over here, subclavius over here, clavicle over here. So this, if breast cancer spreads like this, that is called fixity to chest wall. If it spreads via lymphatics, here, that is one method of spread. Then blood supply, here these two blood supplies are there, right? So it's with that it spreads. So and so about the breast, then we go part by part. Areola, then nipple. You have retracted nipple, and then retracted nipple you have, and then you have this congenital amasia, polymasia, all of those. And then you go to the ducts. You can have, if there's a blockage of duct, there's going to be one secretion, a collection of this thing over there. So all of that will come in your ANDI. ANDI is abnormal aberrations of normal development and involution of the breast. So what they're saying is, at one point of time, the US, they used to have a lot of people getting scared that they have breast cancer. So they were all flocking to the physicians, and they need to find some method to reassure the patient. So they had four type of lesions. One is either a cystic lesion, a papilloma. Other two I don't remember. So these occur normally throughout the thing, the uh, life of a woman, but and it's not malignant, so it's like one aberration. So treatment for that will be different. You don't need to treat it in most of the cases. If the patient is like willingly wanting to do something, then only you treat it. And then this thing, your examination, your examination is your swelling examination. That same swelling examination will come everywhere. Investigation, your mammogram, and then you do genetic, your BRCA 1, 2, P53. So you put those, and then routine investigations you do. Then metastasis, you check if it's there. These are all your investigation. Then treatment, you're going to do chemotherapy. So what, I don't remember the regimen, so I will write 5-fluorouracil methotrexate. And then surgery is there are two procedures. So one is Patty's procedure, and then there's one more with axillary node removal. So that is your another surgery. What they will do is, this is the breast, they'll put one incision like this, they'll take out the lump, then they'll go to the axilla, they'll put an incision over there, they'll take it out, and then you write that pre-operative, intraoperative, post-operative management. So that will be your thing. And other than that, you go to breast carcinoma, there will be some specific for every carcinoma, that loss of weight, loss of appetite you're going to put, so that is not a problem. Two things extra is this dimpling, puckering, and then pudy orange. All of these are due to lymphatic drainage obstruction. Okay, that you need to know one point clinically. Then fixity to chest wall. All of these are points which you can keep just adding. So that is about your breast. Then last you will talk about thyroid. Thyroid. So this is your apex, base, isthmus. You have your recurrent laryngeal nerve, external laryngeal nerve, superior thyroid artery, inferior thyroid artery, thyroid ema artery, and then superior thyroid vein, middle thyroid vein, inferior thyroid vein, and then your lymphatic drainage. You have your pre-tracheal nodes, and then pre-tracheal nodes and pre-laryngeal nodes, and they will drain here like this. Then you go to levels of neck lymph nodes. So this area will be 1, 2, then jugular like this. There 1, 2, 3, 1, 2, 3, 4, 5. Then there will be behind. It will be like that. You need to see the diagram. It's like very methodical if you actually look at it. And then functions of thyroid. So thyroid is controlled by this hypothalamus and pituitary. So from here you have TSH. TSH will go act on this. You have 4 steps for thyroxine production, iodine trapping, then iodide to iodine, and then mono combines with thyroglobulin to monoiodo uh, thyroxine and diiodothyroxine. Then coupling you get T3, T4. This will go bind with thyroglobulin. That is your colloid thing. So this is your histology will be like this. All of this is normal. Okay, and then functions of thyroid is metabolism, and then um, BMR. These two are the ones I can remember off my head. So all your symptoms will be based on this. Your your TSH is similar to FSH, so that's why you have menstrual disturbance when there is thyroid disturbance. Then investigations T3, T4, TSH, your ultrasound, and then FNAC, then true cut biopsy. This you don't do. This you don't do. FNAC is enough. Then then treatment. You're going to do thyroidectomy. Thyroidectomy. So you have four types: total, subtotal, near total, hemi. So total, both lobes anesthemus. Subtotal, you have 8 grams. This bit and this bit are left over, and then near total is you only this bit is left over. Hemithyroidectomy is this much. One lobe and one isthmus are removed, and then again in pre-operative, intraoperative, post-operative management. So I think that would have given you an idea of how to approach an organ. There might be various like thyroiditis or carcinoma or cystic lesion. Cystic now you go to swelling. Carcinoma again swelling. Thyroiditis means you will have some itis means inflammation. Inflammation means neutrophils coming in or antibodies coming in, attacking. So all happen. Fibrosis will happen like that. You just link everything together. The amount of information which you actually need to retain is very very less. So I hope you guys found this useful, and we'll end this session with that here.